Hey there, this is the last part of chapter 6. This is the lecture on the knee. Like we said, we've been breaking this down into smaller chunks so that it's a little more attainable and makes a little bit more sense. So this would be the last part of this chapter. We've looked at these images before, so we won't spend a whole lot of time on them, but I have filled in the answer for you. But this is the anterior view of the tibia and fibula. This is figure 6.17 on page 218. You can see all the anatomy that's listed, and we have discussed, we've looked at the distal end of the tib fib, and now we're at the proximal end of the tibia and fibula that form the knee joint. We can also see this in a lateral view. This is figure 6.18, and we also spoke about the fact that the tibial plateau sits at a 10 to 20 degree slope posteriorly. And the reason that that's significant is because when we angle the tube on an AP knee, the purpose of the angle is to be parallel to the tibial plateau. So depending on the patient's backside, that can range on the angle from direction and degree of angulation, because the tibial plateau has a 10 to 20 degree posterior slope, and that again is on page 218. When we look at the femur, okay, this is on page 219, and the anterior view of the femur, this is figure 6.19. The femur is the longest and strongest bone. When we look at this femur, notice that they reference that the patella sits approximately 1/2 inch above the knee joint, which is important. And then we're going to talk about this 15 to 20 degree angle that they show here. And we're also going to discuss the fact that this is referencing the condyles being parallel to the floor, right? Again, this is figure 6.19. When they talk about this degree of angulation here, they reference that the distal portions of the medial and lateral condyle have smooth articular surfaces that articulate with the tibia. So you have got the medial and lateral condyle articulate with the tibia, and they reference in the next picture, we'll look at that a little bit more, but they talk about that in 6.19, which is this, if you were standing erect in anatomic position and the distal femoral condyles were parallel to the floor like this, there would be, the femoral shaft would be at a 5 to 15 degree angle from vertical. On an average adult, it's about 10 degrees. And it says that the angle would be greater on a person that's shorter in stature and a wider pelvis, and it would be less angle, closer to 5, on a person that was of tall stature with a narrow pelvis. So typically the degree of angulation is greater on a female than on a male, because when we stand, your femurs are not exactly perpendicular to the floor. They actually have an angle, and it depends on the width of the pelvis. Okay, so um, that's an important distinction to be made, because it comes into play not only with positioning of the knee, but when we talk about positioning with the femur as well. Now, the condyles that we talked about, this is looking at the femur from the backside. So these medial and lateral condyles sit at a different degree of angulation. So the medial condyle sits lower, and notice that the lateral condyle sits a little bit higher. Okay, because that medial extends lower and more distally, this 5 to 7 degree angle has to be made up for when we do a lateral knee. So the reason that we discuss that is because on a lateral knee, for every single person, you angle the tube 5 to 7 degrees cephalic in order to put the two condyles to be directly superimposed on top of one another. All right, it has to do not only with the angulation of the shaft of the femur, but just the relative position of the medial condyle sitting lower and more posterior than the lateral. All right, so that will come into play when we look at the lateral knee position. When we look at the distal femur and the patella, because we're looking at the knee joint, which will take into account those, on page 220, they do show you the lateral view and how the femur, you've got the femur coming down, this would be the tibia, and this is the fibula. Remember that patella is the largest sesamoid bone that is formed from friction. Typically, when a baby starts to crawl or walk, that is when the patella is actually formed. It's a flat triangular bone, and it appears like it is upside down, which we will look at in just a minute. Okay. Um, Behind the patella, you have the patellar surface of the femur, where the patella articulates with that. And then the popliteal surface is the area behind the knee. If you look at inferiorly, which is figure 6.22, you can see that the patellar surface of the femur, and this is the patellofemoral joint. So this is what we look at when we do what's called a sunrise view. All right, so these are both on page 220 for reference. The patella, now why it appears upside down is because the base of the patella is actually at the superior border, and the inferior surface is called your apex, or considered the apex. So the point is down, more distal, and the base sits more proximal. Okay, and then you can see from the front, you've got the rough anterior surface, and then the posterior surface where it articulates with the femur is smooth. So base is at the top, apex is at the bottom on a patella. When we look at the knee joint in the oblique views, this one right here is, this oblique view is figure 6.24. Okay, we do both obliques on a knee. We do both a medial and a lateral rotation oblique. You can see on here all the different, the ACL, the anterior cruciate ligament. You can see the posterior cruciate ligament back here, the femur, the fibular collateral ligament, proximal tibiofibular joint right here. All of these um, joints are important, and the four major ligaments are all the different cruciates. I'm sorry, the two cruciates, the anterior and posterior cruciate, and the fibular collateral and the tibial collateral. When we look at this particular image, this is figure 6.25 on page 221. Again, it shows the different anterior and posterior cruciate ligaments. You've got the tibial collateral ligament and the fibular collateral ligament. And you can just see how intricate the knee actually is when we really look at it, not from just a bony perspective, but with the ligaments and everything in there. Knee injuries tend to be a big deal, especially with sports. We see a lot of knee injuries. All right. When we look at radiographic anatomy, we can look at the knee from the anterior surface. So this is an AP left knee. This is on page 222. And again, I went ahead and filled these in for you. So when we look at A, these are the medial and lateral intercondylar tubercles right here. B is a little bit cut off, but that is the lateral epicondyle. C is the lateral condyle, so epicondyles sit above the condyles. And then D represents the lateral condyle of the tibia. E represents the tibial plateau. F is the medial condyle of the tibia. G is the medial condyle of the femur. H is the medial epicondyle of the femur. And then right here, letter I is the patella, which you're actually seeing through the femur right here. When we look at a lateral knee, This is actually an excellent lateral knee. This is true lateral where both condyles are perfectly superimposed over one another. So again, at the top of the patella, we have the base. We have the apex of the patella at the bottom. Not labeled, but this would be the rough anterior surface, and then the smooth posterior surface is back here. C is the tibial tuberosity, right here, that rough prominence on the front of the tibia. D is the fibular neck. E is the fibular head. F is the apex of the fibula. G is perfectly superimposed condyles on the femur, and then H is the patellar surface of the femur. So again, excellent lateral. This is what you're going for every single time you take a lateral knee, is to get these condyles perfectly superimposed. Now, when we look at this, this is actually a rotated lateral knee, okay? How do we know? Well, one, the joint space is not open between the patella and the femur, and then you can see one surface here, and you can see the other surface here. They're not perfectly superimposed. So what they're telling you is that right here, I'll actually highlight that if I can, right here, this is that bump or protrusion is the adductor tubercle, and the adductor tubercle sits on the medial condyle. So this is the medial. J, this one here, is the lateral condyle. Okay, so this right here, this this is a right knee, a lateral right knee. And with this, looking at this, I'll go ahead and erase it now. With looking at that adductor tubercle, if that adductor tubercle that sits on the medial condyle is behind, meaning this is behind the lateral condyle, the only way that can happen is if the knee is under rotated, meaning that they are not rolled lateral enough. They're under rotated because the medial condyle is sitting posterior to the lateral condyle. If the medial condyle and the adductor tubercle were sitting in front of the lateral condyle, then that would mean, hang on, I'm doing this in my chair, under rotated. If it was in front of it, then it would be over rotated. But this is under rotated, okay, because it's medial and it's sitting behind, so it's under rotation of that lateral knee. When we look again, this is a sunrise view. So A represents the patella, B is the patellofemoral joint space, C is the lateral condyle, D is the patellar surface of the femur, and E is the medial condyle. Again, this is on page 222. All right, when we get into the positioning, when we look at a routine knee, there are actually 5 views to a routine knee. They include an AP, both obliques, a 45-degree medial oblique, and a 45-degree lateral oblique, a lateral knee, and one view of the sunrise patella. Okay, those are the routine views for a knee. If we look at AP knee, that is actually on page 247 of your textbook. All right, it's an AP projection. This will show any fractures or lesions or bony changes related to degenerative joint disease in the distal femur or the proximal tibia and fibula, along with the patella and the knee joint. We are at a 40-inch SID, and this is most likely on adults. You are going to be in the bucky because most adult knees are thicker than 10 centimeters. Your technique on this would be 80 kVp at 3 Mass. and you are collimated to a 10 by 12 portrait. Okay, so 14 by 17 in the Bucky, 40-inch SID, collimated to a 10 by 12, and 80 kVp at 3 mass. I know this says 4, but honestly, I should have changed it because in talking to the sites, I find that they now with the digital equipment, they're able to go even lower. So I would argue 80 kVp at 4 mass is what we would use. The patient would lie on their back unless these were ordered weight bearing. They would lie on their back on the table. You would ideally try to get the affected leg towards the middle of the table, and you're going to rotate the entire leg internally 3 to 5 degrees so that you get a true AP knee. Okay, so 3 to 5 degree rotation internally. The central ray has to be parallel to the tibial plateau, and it is 1/2 inch distal to the apex of the patella. Now, how do we know where the tibial plateau is? Well, that comes into play where we have to measure from the patient's ACES to the tabletop. We use that L-shaped ruler, which are called calipers. And how this works is if the patient measures less than 19 centimeters, then you're angling 3 to 5 degrees caudal or towards the tail. So if they have really thin thighs and small butt, like a tiny hiney, then you're ideally 3 to 5 caudal. If they're average and they measure between like 19 and 24 centimeters from the ACES to the tabletop, there is no angle on the tube. And if they measure greater than 24 centimeters, then you are angling 3 to 5 degrees cephalic. So that would be a patient that's a little bit thicker in the thighs and in the butt cheeks. So thicker, 3 to 5 cephalic, tiny hiney, 3 to 5 caudal, average between 19 and 24, no angle on the tube. Those measurements, when they measure whatever they measure, and these angles, whether it's no angle or 3 to 5 cephalic or caudal, will place you parallel to the tibial plateau. And then we're 1/2 inch distal to the apex of the patella. Okay, so it's important on the AP there is an angle. If we do this correctly, then the femorotibial joint space is open, meaning the knee joint will appear open. The knee should be centered to the center of your field. The articular facets are profiled, and this is a nice AP knee. It is different from the one in the book on page 247. Okay, the one in the book they tell you is a 0 degree, meaning the patient must have measured between 19 and 24 centimeters. Ideally, 12 inches in length gets you enough of the distal femur and proximal tibia fibula. And we can see here again, this is a small patient, a pediatric patient, because there are epiphyseal plates or growth plates on all 3 bones, the fibula, the tibia, and the femur. All right, our first oblique will be our medial oblique. Now this is kind of similar to the elbow. They talk about a medial rotation. This is a 45 degree medial oblique. Okay, 45 degree medial oblique, and you have to take the angle off the tube. So you did your AP with or without an angle, but if there was an angle, you're going back to 0 degrees and perpendicular for this particular image. Okay, your central ray is still 1/2 inch distal to the apex of the patella. You're still at a 40-inch SID, 2 Bucky, collimated 10 by 12 portrait, and you're rotating the patient's entire leg internally 45 degrees. All right, typically we look at the kneecap to know that that rotation is happening, no angle on the tube, and your mid knee half an inch distal to the apex. So what they're showing you is half an inch distal to the apex is right here where this dotted line is, but you're centering on the knee so that you end up with equal light fields on either side of the knee. All right, now this is the one that I tell you, ideally I would say put the marker to the right of the part, but then that would place you inside the patient's legs over here, and that's probably not comfortable. It's probably a little creepy for the patient, so I would then place the correct anatomic marker, but on the side closest to you versus inside the patient. All right, so no angle on the CR. This is going to demonstrate the fibular head and neck free of superimposition. I don't have an x-ray of this, but if you look at 6.108 in the book, the fibular head and neck are free of superimposition from the tibia, and the patella ends up being half on, half off the femur. I actually have it after this one. I have both of them for comparison. After you do that, then we will do the 45-degree lateral oblique. All right, so this is going to be coming out, away from midline. All your factors are still the same, 80 kVp at 3 mass, 40-inch SID to the Bucky, 10 by 12 portrait. Now you take the leg and rotate the entire leg 45 degrees laterally, and your central ray is 1/2 inch distal to the apex of the patella in the center of the knee. Now this collimation doesn't really look like 12 to me, but I would think it would be a little bit more open on there. Again, the tibia now for this is in profile. So the acronym for this is FITE, F-I-T-E. The F-I, what that F-I represents is that the fibular head and neck are free of superimposition on the internal, and the T-E represents that the tibia is in profile on the external. So the acronym is FITE for both of these obliques, and the patella should be half on, half off the femur. So FITE, F-I-T-E. When we do this on the 45 medial or the internal, the fibular head and neck are free from superimposition by the tibia. Okay, so this is the 45-degree medial or the internal oblique, and the patella is half on, half off the femur. So that's a really nice femur, or I'm sorry, a really nice internal knee. This is the 45-degree lateral oblique, and on this one, the tibia is actually in profile. And again, the patella is half on, half off the femur. No matter what, because this is a good image, as is the one on 249, but personally, I find that the 45-degree lateral obliques are just ugly. I don't know what it is, but that to me is just an ugly picture. It doesn't look like it should be correct. This one looks pretty because seeing something free of superimposition, seeing the joint space like that, seeing the femur looks good. This one to me just always looks like it's incorrect, but I'm telling you it's not. So on the external, the TE, the tibia is in profile, and on the FI, the fibular head and neck is free of superimposition on the internal. So internal is the 45-degree medial, external is the 45-degree lateral oblique. We do a medial lateral. This is on page 250. Okay, so what you're going to do, so we angled on the first one, the AP. We took the angle off for both obliques, and now we are going to angle again for every single person, regardless of their backside size, regardless of anything, you are angling 5 to 7 degrees cephalic for every single patient, because that is the only thing that will place the condyles superimposed over one another. Because remember, the medial sits lower, and the degree of angulation between the medial and lateral condyle is 5 to 7 degrees. So by angling, that allows us to superimpose them perfectly. So patient rolls laterally towards the affected knee. We put a 5 to 7 degree angle on the tube, and the central ray now is 1 inch distal to the medial epicondyle. That's honestly going to be in the same level as 1/2 inch distal to the apex, except that when you're 1/2 inch distal to the apex, now you're just rolling that up on top. You can see the medial condyle right here, medial epicondyle, I'm sorry, right here, and you're 1 inch below that. And there is approximately a 20 to 30 degree flex in the knee. Okay, not a huge amount of flexion in the knee, not like 45 or anything. A slight bend in the knee, 20 to 30 degrees, 5 to 7 degrees cephalic angle. You can see that that's angled, and you're 1 inch below medial epicondyle, which is at the same exact level of a 1/2 inch distal to the apex. You're just rolling that up on top. All right. If this was a trauma patient, you would then do a horizontal beam or a cross table lateral. All right. This is the cross table lateral knee. This is just a non-trauma lateral. And remember, if done correctly, then we should have perfect superimposition of the medial and lateral condyles. We should see an open patellofemoral joint space. All right, this is perfection right here, as is the one on page 250, figure 6.113 and 6.114. Those are perfect because the condyles are perfectly superimposed. All right. Now, sometimes they will order or they will make standard protocol if the patient is ambulatory or walkie-talkie. They will order knees weight bearing. Okay. And when they order knees weight bearing, this is on page 251. All right, so on page 251, we have AP bilateral weight bearing knees. When they order weight bearing knees, it's typically like Advent's protocol is to do weight bearing knees anytime the patient is ambulatory. Honest, Advent typically says that knees, hips, and ankles should be done weight bearing anytime the patient is ambulatory, meaning they come in walkie-talkie, then all of those images should be done with the patient's own body weight, because it definitely shows the joints and how they behave under the weight of the patient. So typically this is done AP bilateral weight bearing, and if so, then the central ray typically is not angled, and you are centered mid 1/2 inch distal to the apex, midway between both knees. Notice they've got the marker here and they've got an arrow to say that it was done upright. Okay, so you would be 40 inches, 14 by 17 landscape if they had bilateral weight-bearing knees. And then typically it's perpendicular to the IR with the central ray, midway between the joints, a 1/2 inch distal to the apex. All right, and that's on page 251. And that image would then look like this. You can see both knees on there, and then it shows how the joints behave under the patient's own body weight. So you see distal femur, proximal tibia and fibula, and the femoral tibial joint space demonstrated bilaterally. All right, but because it's under the patient's own body weight, typically that's what they like to see with ankles, knees, and hips a lot of times. All right. So we've looked at the AP knee, we've looked at both obliques, the 45-degree medial and the 45-degree lateral oblique, and we looked at the lateral. The AP weight bearing was just another alternative that a lot of facilities do. Now, the last view in a routine knee is the sunrise view. All right. And when we look at the sunrise view or the patellofemoral joint, the images for those, there are different options to do these. They are tangential views, meaning that they're skimming the part. All right. And these begin on page, let me find these for you. Um, on page 259, this particular picture is the Merchant method. Okay, this is a bilateral Merchant method since you're doing both knees. Typically with the patella, the sunrise view, it can either be a unilateral or it can be bilateral. So this is the Merchant view. That is one option. And with that, you would need the Merchant board, which I'll show you in just a second. That's this right here. There's a Merchant view. There is an infra superior that would give you the sunrise. There's a Houston method and a Setagast method. There's also a supero-inferior sitting tangential method and the Hobbs method. Okay, so we will flip through these, and starting on page 259 is the bilateral Merchant method. And like we said, with that you would need what's called the Merchant board, and it's an adjustable leg support, and it holds the image receptor so that you can actually capture the patient's patellas on there and be able to visualize those. So this is what it looks like. The knees are flexed 40 degrees and the central ray is angled 30 degrees from horizontal, and this represents the central ray. I don't know of any of our facilities that actually have the Merchant board or do it, but this is what it would look like on there. You can see the intercondylar sulcus and patella are visualized. The femoral patella joint spaces are both open. You're looking between the femur and the patella on both. This would be left, this would be right. Typically we mark them both, and that is actually a decent image. I'm not sure why they have this one positioned lower. If you look on page 259, the image that they show in both radiographs is actually a lot better. The knees are at least equivocal on there. Then we have the infrasuperior projection. This is actually on page 260. This and the Houston method. So the infrasuperior axial is figure 6.138 on page 260. There's 40 to 45 degree flexion of the knees, and the central ray is angled 10 to 15 degrees from the lower legs. You can see that right here. The central ray, the tube would be coming up this way. Now, this is very similar. Remember when we looked at the axial butterfly on the barium enema, and we said there were 4 different options to get one butterfly view. There was the AP axial, there was the AP axial oblique, there was the PA axial, and the PA axial oblique. So all 4 of those would straighten out the rectosigmoid region, but we only did one. So same thing holds true with this. There are many ways to capture a sunrise view, but you only are doing one. So wherever you go, whatever your facility deems as what they do, or different techs might do different methods, which is perfectly fine. As long as you get the image, that is truly all the radiologist cares about, but there are multiple ways to get that image. So this is the infrasuperior axial. on 260, and then also on 260 they show you the Houston method, where the knee is flexed approximately 40 degrees and the central ray is 15 to 20 degrees to the lower leg. Okay. Then we have on the next page on 261, we have the Settegast method, and this is with the patient seated. Right? So on the Settegast, when they're seated, then the central ray is to the patellofemoral joint space, but it's approximately 15 to 20 degrees from the lower leg, and it would skim right up. The patient is holding the IR. Typically, we don't allow the patients to hold the digital receptors just because they're so expensive, but this is what it would look like. Now, they reference that a disadvantage to this is that you can overflex the knee and it'll actually draw the patella into the intercondylar sulcus. Okay, so that is not what we want. We don't want to draw. A major disadvantage of that, like I said, is to draw the patella, into the intercondylar sulcus. We also have the Hobbs modification on 262, where the patient is seated. You can see how she's seated right here. The knees are flexed. The IR is placed on a footstool to reduce OID. And then you would have to raise your SID to compensate for that to about 48 to 50 inches. And then you can see the central ray is perpendicular to the IR, and you're centered mid-patellofemoral joint. Right? So this is what it would look like from up above, but this is what it looks like from the side view of that. And then if that is done correctly, this is what that image would look like, 6.143 on page 262. All right, so many different options to get what we call a sunrise view, which is a tangential view of the patella and the patellofemoral joint space. Tangential means skimming a part. Okay, so there's the Hobbs modification, the Settegast, the infrasuperior axial, the Houston, the bilateral merchant. All of those are options to get the one view needed with the patella for a routine knee. Okay. All right. When we look at one of your pathologies is what's called a bipartite patella. This is not in your book. I pulled these slides to show you, because what that means, what a bipartite patella is they're two separate bones from birth. So these form, and they're actually two separate bones that form from birth, and they remain separate throughout the patient's life. Okay, and there's three classifications. So if you were to do this image, it can appear like there is a fracture in the patella. Especially on the sunrise, that definitely looks like a fractured patella, but that is not. That is considered a bipartite patella. So it's a congenital defect, meaning they're born with it, but it typically doesn't manifest or show until the patient has knee images, and then they could consider that to be a fracture, but it's not. The three classifications of this, type 1 is where the two pieces are typically like this. You have one large chunk of the patella and then the apex is separate. Type 2 is where there's a lateral piece, so you have the bulk of the apex and then one piece that sits lateral. And type 3 is typically not really at a right angle to it, but usually just a chunk at the top of one side or the other. This is what that picture previous was a type 3 bipartite patella. Okay, again, not in the book, but it is a common congenital defect, and a lot of times it can be mistaken for a fractured patella. Looking at the routine for a patella, we actually do two views for that. We do a PA patella, which places the part closer to the IR and reduces OID. All right, and this is actually on page 257. So the patient would be PA at a 40-inch SID to the Bucky. You're probably collimated to an 8 by 10 on this. And then you want to make sure the patient's in a true AP. So you typically have to have about a 5-degree internal rotation of the anterior knee. The central ray is perpendicular, and you're actually centered to the mid-patella, which is typically the mid-popliteal crease in the knee. So the bend of the knee at the back, you're centered mid-patella, which is mid-popliteal crease. And if that is done correctly, then this is what your image would look like. The patella is centered. You can see it right here. You've got the base of the patella, and then you've got the apex of the patella right here. Ideally, there's no rotation to that, and this looks similar to figure 6.131 on page 257. The second view for a patella would be a lateral. It is a mediolateral, so we roll it just like we're doing a lateral knee, but the central ray is anterior on this. Your central ray is to the mid-femoral patellar joint space. Okay, so you're a little bit more anterior on that. So you can see the patella right here, and you're coming anterior to the mid-femoral patella joint space. So with this, you rotate the body and leg until the knee is in a true lateral. It's flexed, the leg is flexed approximately 5 to 10 degrees, and the central ray is perpendicular to the mid-patellofemoral joint. You can also do this as a horizontal beam lateral, meaning a cross table lateral. All right, so notice when we are doing this for a lateral knee, if this is medial condyle, we would be 1 inch below medial condyle here, but now we're coming a little bit in line with the condyle, just anterior to that, so that you're only getting this area because your interest is the patella. If that is done correctly, then you can see we have exactly like we did for a lateral knee, where the condyles are perfectly superimposed, but you're ideally looking at this area and the patella more so. You're looking at the patellofemoral joint space and the lateral of the patella itself. And this is on page 258, figure 6.133. So you get a profile of the patella, the patellofemoral joint, and the femorotibial joint. Okay, so routine patella is a PA and a medial-lateral projection lateral, or PA and a lateral of the patella. Routine for a knee is an AP, both a 45-degree medial and 45-degree lateral oblique, a lateral knee, and a sunrise view. All right, so that takes us through chapter 6. I hope that you took good notes on this. I hope that you wrote any comments or questions or concerns that you might have so that we can address those during class and during our time together. But until then, I hope you were able to review this information and just look at those images one more time, and I hope you have a great rest of your evening. Thank you so much.